Thank you guys for making the time to come to our breakout session. This is San Diego Fertility Center, so double check you're in the right place. So this conference can be so overwhelming. So our biggest advice to all intended parents is to break your journey up into 3 parts. Part 1 is sperm. Okay, so you come to our center, you give us sperm, and we freeze. Easy. Part 2, find an egg donor. We have our own in-house egg donor database. You don't have to use it, but it is more affordable because you don't pay us an agency fee. And our donors are already medically screened, so you don't have to pay for that. So you create embryos and you freeze. That's the end of part 2, super easy. Part 3 is the hardest part, is finding a surrogacy agency who will then, and we'll help you find the right agency, who will then give you profiles of surrogates that we then medically vet and we do the transfer. So if you keep the journey into 3 separate parts, you will not get overwhelmed. I know many times people start with the surrogacy agency, which is fantastic, but don't contract with any surrogate until you've already had embryos made. Okay.
So I'm Dr. Saeed Danishman, Dr. Park's partner. So one of the areas that we have had a great deal of strength in has been clinical research. And I think it's through research that we're able to really push the frontiers of success and safety in the field of in vitro fertilization. For example, we've done a lot of research on endometrial receptivity, meaning how can we make the uterus most receptive at the time of embryo transfer so that when we transfer an embryo, we have a very high rate of implantation. So we published a lot of work on that regard. We've published a great deal of work on something called ovarian hyperstimulation syndrome. When your egg donors go through the stimulation process, they're going to make lots of eggs. Sometimes they can hyperstimulate, meaning that they have all this fluid that basically collects inside their abdomen. They can have a higher risk of something called blood clots, DVTs. So what we've done is we now have a specific mechanism by which we prevent ovarian hyperstimulation syndrome. And the third area we published on is the area of embryo assessment. How do we determine which embryos are the best quality embryos so that when we transfer one single embryo into a very receptive uterus, we're going to maximize the chance of pregnancy? Now, in regards to assessing embryos, there are 2 ways that we can assess embryos. The first way is we look under the microscope and we look at objective cellular criteria, meaning we look at the cells of the embryo and how they're sort of put together. And we can really grade embryos based on how the inner cell mass looks like. Those are the cells that give rise to the fetus. And then the trophectoderm cells. And those are the cells that give rise to the placenta and the gestational sac. So that's what we call morphological grading or assessment of the embryo. The second way in which we can assess embryos is by genetic analysis. And you're going to hear during this conference a lot of talk about PGS or PGT. This is pre-implantation genetic screening or testing, where we actually have to create a little hole in the embryo shell, and then we pull 3 or 4 cells out, do a biopsy of the outer shell of the embryo, and then we take those cells and send it to our genetic analysis, the Genetics Institute, to look at chromosomal abnormalities such as Down syndrome. Now, chromosomal abnormalities such as Down syndrome are completely related to the quality of the eggs, and the quality of the eggs is related to the age of the woman. So when you use young egg donors, the risk of chromosomal abnormalities is very low. So do you need to do PGT? No. We will discuss with you based on research what research shows. In other words, if you have good quality sperm, you have a young egg donor with good quality eggs, then there's no reason to do PGT because that's an extra cost. And in fact, clinics derive a higher profit when they do PGT or PGS. We base our decisions on research and clinical experience. Now, there are certain times when we do the biopsy, and when we do the biopsy, some embryos can be harmed by the biopsy. About 10 to 15% of embryos can be fragile, and when you do the biopsy, they can stop developing. It doesn't lead to an abnormal pregnancy, but we've now lost that particular embryo. So the latest research that we're doing at our center is not doing the biopsy, but actually when we grow the embryo, and remember the embryo grows for about 5 to 6 days in the lab, and we grow the embryo in a fluid called a culture media, and that embryo sheds cells and DNA into that culture media. So we're taking that DNA and we're analyzing that DNA for the chromosome analysis. Now in about a year and a half, we're going to have all the results. We're going to correlate those results from the media to the biopsy, and if we get a really good correlation, no longer would we need to do the biopsy on the embryo. We don't have to touch the embryo, and that's going to really revolutionize the field of PGT and PGS. And I think what it also will do is bring down the costs of this particular procedure so you don't have to pay several $1,000s. For some intended parents, they want to do sex selection. And the only mechanism to do it now is through the biopsy. So that's sort of our latest research, and in fact, all of you are eligible. If you wanted to participate in the research, you could. There's some incentives. For example, it decreases the cost of the analysis a little bit. But the first sort of order of business is we want to make sure that PGS or PGT is really indicated, that you really need it. Because in the majority of instances, when you have a young egg donor with good quality eggs and you have good quality sperm, the risks are so low that it's really not required.
Do you want to tell them how many centers are on the world doing it?
So this particular study involves 6 centers around the world, only 6 centers. And we're really, I think, lucky to be one of the centers selected. And I think we're one of 2 centers in the US that have been selected to conduct this particular study.
I know, right?
One on the East Coast, one on the West Coast.
Right.
So it's exciting stuff. For us, it's the research and sort of the advancements in technology and science, helping parents have healthy pregnancies are some of the most exciting things that we do at the office.
So now the way we like to do, our session is we like to open it up to questions and answers about anything. It doesn't have to be about San Diego Fertility Center. It could be about anything, and there is no dumb question.
Well, thank you. So you mentioned a lot of things that have to do with the age of the donor. Are there any other things than age, such as likelihood of pregnancy and other things that are correlated with the age of the donor?
So when you look at the rates of implantation or success rates, in other words, when we transfer an embryo back into the uterus, what are the parameters that predict success? The quality of the eggs are important. The quality of the eggs are related to the age of the egg donor. At San Diego Fertility Center, we have an egg donor database where all the egg donors are pre-screened. That means they've already done their genetic screening, psychological testing, and egg quality testing, and egg counts. So egg quality and egg count. The other factor is sperm quality. We always want you to have a sperm analysis done before you come to us. Why? Because if there are any abnormalities with the sperm, we want to make sure we put you either on medications, antioxidants, or vitamins for a couple of months before you give us a sperm collection so we can maximize the quality of the sperm. And the third component is what we just talked about is your surrogate, the health of your surrogate, and how receptive her uterus is at the time of embryo transfer. And we've, again, developed protocols based on the research that we've published to know exactly when the uterus is receptive. So that's the exact moment where we transfer the embryo back in. So those are the 3 components that really predict success. And a great doctor.
Any other questions? Yep.
Besides Down syndrome and cystic fibrosis, what are some of the biggest genetic abnormalities that you guys look for?
Okay, so I'm going to explain, because people get this confused all the time. There are 2 types of genetic abnormalities, okay? So we all have chromosomes, 23 from our egg source, 23 from the sperm source, okay? Embedded inside the chromosome is our DNA, how tall we are, our eye color, our hair color. Cystic fibrosis is an example of a mutation within the DNA. But cystic fibrosis is what we call an autosomal recessive mutation. What that means is, let's say you got the CF mutation from the egg source, but you didn't get it from your sperm source. So you're just simply a carrier, but you're not affected by it. However, if you've got the CF mutation from the egg source and the sperm source, you are now affected with the actual CF disease. Okay? So DNA mutation screening, which is a simple blood test in you being the sperm source and in the egg source, checks to make sure that you two do not have the same DNA mutations. We all have mutations. It's part of being human, but look how normal we are. You just want to make sure that you are compatible. Okay?
So your offspring is going to have 50% chance of having it.
Correct. Okay? But that is not the same as Down syndrome. Down syndrome is numerical problem. We're not looking at DNA mutations. We're just stepping back and counting the number of chromosomes. It should be 23 from the egg source, 23 from the sperm source. However, as eggs get older, why is the risk of Down syndrome higher? Because when eggs get older, they have 46 chromosomes. At the time they ovulate, it splits 23-23. The older the egg source, the more uneven the split. So let's say you have 24 and 22. If we fertilize one of those eggs with your sperm, your embryo is either going to have one too many chromosomes or one less. So Down syndrome is not a case of DNA mutation, it's a case of incorrect number of chromosomes. And you only know that once the sperm and the egg have merged. But the incidence of incorrect number of chromosomes is very low when your egg source is in her 20s.
So the genetic test that you're doing on yourself with the Invitae is different than the PGS testing because the PGS testing is kind of testing for the
number of chromosomes, whereas Invitae checks DNA mutations in you and the egg source long before you start the process. Does that make sense? Yep.
And the other thing to follow is that when your surrogate is 9 to 10 weeks pregnant, you can do a blood test on her without risk, and it's called a non-invasive prenatal test, a NIP test. And that test will tell you the same information as the PGT or PGS, meaning that it'll tell you the presence of major chromosomal abnormalities such as Downs. It's a blood test that's done in 9 to 10 weeks, very accurate. There are many, many different genetic companies that run that test. Yes?
Is there a specific age where you would recommend an egg donor?
So typically, most egg donors, the recommendation is between 21 and 29 years of age. Now, if you have an egg donor in mind, let's say that we have many intended fathers who actually have a friend and they want that friend to be the egg donor and she may be in her 30s, we just discuss with you the chances of how many embryos we're going to get, what the pregnancy success is going to be based on the egg donor's age. But if we recruit egg donors between 21 and 29 years of age. That's the time frame when they have the best quality eggs.
Yep.
So what are some things that would not have been picked up in PGS testing? I'm sure there are all kinds of key things, conditions that would not be traceable.
Right, microdeletions will not be visible, correct. So did I ask you a question? So it counts the number of copies of chromosome. So for example, Down syndrome is 3 copies of 21, right? So when it scans, it'll realize that the quantity of chromosome 21 is much higher than the quantity of all the other chromosomes. So already you know you have excess material. But microdeletions will not get picked up on it. I'm not sure if I answered your question.
And there are other genetic syndromes that don't get picked up. For example, there are whole lists of malformations, genetic malformations, and those are not going to be picked up by the PGS. PGS, it's almost like PGS looks at the chromosomes, and it's almost like looking at a road every 4 miles. If you got a 20-mile road, and you're looking at the road every 4. But what happens between 0 and 4, you're not going to know. So, microdeletions, Dr. Park said, there are genetic syndromes. Malformations associated with the kidneys and the heart and the brain. Those thankfully are very, very low risk. Those cannot be picked up. And PGS, like any test, has a false positive and a false negative rate as well. So.
And just as every clinic is different, but in our clinic we do not see a difference in the egg donor surrogate world of intended parents who do PGS versus do not in terms of implantation rates or miscarriage rates. We don't. So as a center, we're very neutral on it. We are not strong advocates of PGS, nor are we against it. We're very neutral on it. And frankly, most people do it for gender selection. I mean, in this population, it's the 42-year-old woman, it's a totally different story, right?
The best study on PGS is a study that was done in 34 clinics, multi-center clinic, a multi-center trial, 34 clinics globally around the world. They looked at different age groups, PGS versus non-PGS, and they looked at patients, women under the age of 35. The rate of pregnancy with PGS was 47%, rate of delivery, and without PGS was 53%. So that's one of probably the best studies that are out there. Who has not asked a question yet? I think, did we have?
Oh.
Okay, so, yeah.
Patrick, it's your turn.
So fresh versus frozen eggs, we don't recommend using frozen eggs. Eggs are more fragile than embryos. There's no difference between fresh and frozen embryos in terms of success rates, but there is a big difference between fresh and frozen eggs. So we typically recommend using fresh eggs, fertilizing them, creating the embryos, and then freezing the embryos. So when you look at pregnancy rates with frozen eggs, they're in the range of somewhere between 47 to 55%. And when you look at frozen embryo transfer pregnancy rates, where the eggs were taken fresh and then the embryos were frozen, those are closer to 80 to 90%.
So keep this in mind, right? When you defrost a frozen embryo, the survival rate for thawing is over 95%. When you defrost a frozen egg, the survival rate was horrific, used to be 30%, but now with vitrification, we've got it up to 70 to 80%, which is really good, but it's not as good as 95. Okay, sorry. The second thing is, so let's say, because usually when you buy lots of frozen eggs and lots of 6, right? So you defrost it. Okay, so 1 doesn't survive, so you have 5. When you ICSI with sperm, the fertilization rate is 70 to 80%. So if you put sperm into 5 eggs, you may end up with 3 fertilized eggs. Does that make sense? So, and then you have to grow the 5 days. You may end up with really 1 embryo, right? Versus when you have fresh eggs, you start off with many more eggs. So of course you're going to lose some along the way, but you won't end up with 1. And if you have 2 sperm sources, buying frozen eggs is not wise because you buy them in lots of 6. So with 2 sperm sources, what's the likelihood you're each going to get an embryo?
Yeah.
Pretty small.
Yeah.
And it's not as if it's that cheap to buy 6 frozen eggs. You're going to have to buy 2 sets of 6 frozen eggs. But with that cost, you're better off just doing a fresh cycle. It'll be cheaper.
And that's such a great point because when fathers are splitting the eggs between the 2 of them, and we want to have at least 1 to 2 to 3 embryos for each, it's really important to be able to use fresh eggs, and not only just fresh eggs, but donors who create a good number of eggs. Because we can predict based on egg quality and egg count screening how many of those eggs are going to develop into embryos. So really want to discuss with you when you choose your egg donors, whether these particular egg donors are going to give us the number of embryos that you are wishing. Some intended fathers say, well, I only want to have 1 child. If you want to have an adventure like me and have 3 children, you're going to need more embryos. You're going to need more eggs. So I don't necessarily recommend that, but still. Especially 3 teenage daughters I have right now. So these are harrowing times. But no, we really want to we want to build your whole family with 1 egg donation.